Good afternoon, and thank you for joining us today for our October's Women's Health webinar, Addressing Intimate Partner Violence During Pregnancy and Beyond. My name is Iman, and I'm the Program Manager here at the National Healthy Start Association. So for our agenda for today, we'll go into logistics about the National Healthy Start Association. We'll move into our presentation for the day. We'll have a Q&A, and then we'll close out our webinar. So just as a disclaimer, thank you again for joining this webinar today. By joining, you have consented to being recorded with your camera and your name on the screen, or with your camera off and your name appearing on the recording. If you decline consent, you may leave the session now and watch the recording later. NHSA may be interested in sharing excerpts of this recording in other media channels. If you are featured in an excerpt we'd like to share, we will contact you and to request your permission prior to use. And the opinions and content expressed in this presentation and on the following slides are solely those of the presenter and not necessarily endorsed or supported by the National Healthy Start Association, its board, staff, affiliate programs, partners, and services. So for logistics, there are two ways to listen: through your computer speakers or on the phone. We ask you to please not use both methods, and feel free to add any comments or questions in the chat box. And if you'd like to come off mute, please use the raise your hand feature. So about the National Healthy Start Association, our four pillars are advocacy for Healthy Start programs, training, technical and capacity building, coaching and mentoring, and developing and disseminating resources and tools. Our three learning objectives for the day are to learn why addressing IPV during pregnancy and postpartum are important, develop an understanding of the universal education approach to addressing IPV, and to explore ways that organizations can address IPV using the AMCCI IPV Safety Bundle and Learning Series. So our first speaker for the day is Rebecca Livingston. Oops, sorry, give me 1 second. And she is a former senior policy analyst and now consultant with Futures Without Violence, and has been working with home visitors and perinatal case management programs for over 25 years. She is deeply committed to taking care of staff as a first step in the work of addressing family trauma and intimate partner violence. Ms. Livingston is the co-author of numerous publications and domestic violence training resources, including Futures curricula for perinatal case management and home visitation programs on how to address domestic violence. Our second presenter is Dr. Ashley Calderon, and she is the Clinical Implementation Manager with the AIM-CCI project. She has clinical experience in pediatric, postpartum, and neonatal intensive care units. Ashley is a subject matter expert in the field of lactation, and her interests include improving teamwork and communication, standardizing processes, and breaking silos to create more equitable systems of care. She is also interested in programs aimed at improving access to quality health care as a means of addressing preventable maternal morbidity and mortality through quality improvement. Ashley earned her Doctor of Nursing practice from the University of Central Florida with a focus in nursing systems, and she holds degrees in nursing and health education and behavioral from University of Florida. And now I will turn it over to our speakers for the day. Thank you.
Thank you, and forgive me, I'm just going to take 1 second to pull up my slides now. Can you just let me know if you can see the slides?
Yes, I see them. Great, thank you.
Great. So Ashley, I'm gonna hand it over to you to talk about the AIM-CCI IPV bundle.
That sounds great, Rebecca. Thank you so much. And thank you, Iman, for the introduction. Good afternoon. I just want to welcome everyone again for joining us. My name is Ashley Calderon, and as Iman said, I'm the Clinical Implementation Manager with AIM-CCI. And before we jump into the meat of the IPV discussion, I just want to take a few minutes and talk about what really brought us here today and some background information on what AIM-CCI is and what we're doing in regard to maternal morbidity and mortality. So what is AIM-CCI? It's really no secret that the United States is facing a crisis when it comes to maternal morbidity and mortality. But when we look at the data, right, it tells us that a majority of those numbers actually occur outside of the hospital walls. And so HRSA has recognized this and therefore developed the AIM-CCI project, the Alliance for Innovation on Maternal Health Community Care Initiative. And this project was awarded to the National Healthy Start Association with the purpose of creating non-hospital focused maternal safety bundles to be implemented in community and centered in equity. Next slide, please. So I want to make sure we all are able to define a bundle. And a bundle is, in essence, it's a small set of evidence-based practices that when carried out together and systematically will help improve outcomes. Next slide, please. So AIM-CCI has created community safety bundles that have been tested in 6 communities across the country. Currently, there are 2 bundles available on our website. One addresses postpartum safety and wellness, and another addresses caring for maternal mental health and well-being. And so why we're here today is to tell you that on October 15th, we are going to be making public our community care to address intimate partner violence during and after pregnancy. All of the information, once it is available, will be sent out to all attendees on the webinar today. Next slide, please. And this slide just gives you a little bit of a sneak peek into what those bundles look like. We have foundational level actions that are incorporated into all of the community care bundles. And then there's also resources that help to provide support with implementation and or provide evidence behind why that action is essential. So when we look at community and we look at developing community-based bundles, we want to think outside of what traditional, hospital-centered clinical focused bundles have looked like. And while those are important, those aren't necessarily going to be your major touch points in community. So when we talked about what pressing matters there are, we cannot avoid the topic of IPV, really. And so the purpose of this bundle was to raise awareness and prevent violent deaths during pregnancy and throughout the postpartum period. And we also want to improve data collection to further the body of evidence. And Rebecca's going to talk more about why that's important in a moment. As always, with all of the work with AIM-CCI and National Healthy Start Association, we center our work in racial justice and health equity. And again, we want to elevate the issue of IPV, specifically when we're looking at maternal morbidity and mortality, and particularly after these last 2 years following the COVID pandemic, when we've seen news articles way too frequently about this topic. Next slide. So I am joined today by Rebecca Levinson, who is representing Futures Without Violence and National Health Resource Center on Domestic Violence. Rebecca was one of our very esteemed subject matter experts who worked with us on bundle development for the IPV bundle, as well as an accompanying online learning series that will support bundle implementation, and we will tell you more about later in this presentation. So Rebecca, I'm going to hand it back over to you.
Thank you, Ashley, and thank you, Iman, for your words earlier. This is a very sweet moment for me because I had the opportunity to do the clinical side of perinatal case management many, many, many moons ago and became a director in that environment. And then I have been at Futures for 23 years, and my very first project was a Healthy Start sole source contract to Futures to work with home visitation sites across the country. So I did 32 site visits over the course of 2 years, and I got to know and enjoy the wisdom of folks across the country. And one of those folks that I always tell a story about is this woman named Lo Berry in Jacksonville, Florida. And when I was going out, she was one of the first site visits I did. She said, Rebecca, you should separate the frontline staff from the supervisors so you really can understand like what's in the way around IPV and their spaces. And I did that. I did that for all the sites across the country. And, when we say we do centric work, we're talking about having worked with nurses or worked with doctors, healthcare systems, home visitation, perinatal case management, and bringing the best of everything to you with voices of advocates, with voices of survivors, et cetera. So anyway, with no further ado, I'm very excited about today. Ashley mentioned that we created an e-learning bundle that's getting launched on October 15th. And I wanted to just give you a quick overview of some of what's in there so you get excited about going through the series or encouraging your colleagues to go through the series. As mentioned in my bio, I'm a big believer in we have to take care of the people who take care of the people first. So recognizing vicarious trauma, secondary trauma, and how we help support staff if they get disclosures is a really important place to start, as is their personal safety. So what do we need to do in clinical settings and in home visitation settings to help keep home visitors and others safe? Of course, no surprise, we're going to talk about intimate partner violence definitions, prevalence, and dynamics. We're going to talk about the health impact. And, what we're hoping to do with this e-learning series is push the field to make different connections than maybe you have in the past and develop different strategies and different ideas about community partnership. One of the other things that we're going to be doing is looking at IPV screening tool limitations and what are the barriers to disclosing IPV and how can we be thinking about that as a key component as we're moving forward in conversations about building equity across systems. We're going to be looking at racism and implicit bias and how that factors into our work in this e-learning bundle. We're going to be recognizing the limitations of the medical model and who it is not serving and what strategies are out there that make a difference. Things like the JJ way and centering pregnancy. We're going to be looking at universal education as a way to center equity, and CUES is our universal education evidence-based intervention, which you'll be hearing about today. And then we're going to be talking about safer versus safety planning. And the difference is safer planning is client-led, right? You're the expert in your own experience. And we, as your case managers, as your home visitors, are going to follow your direction on what we can do to help you in this moment. And then we're also going to be talking about developing culturally responsive supports. So sometimes that includes domestic violence advocacy. Sometimes it includes developing MOUs with DV programs, but it also might include faith-based organizations in your community, other kinds of supports that exist, because of course, each community is unique and it's about pulling out the best of what's there. So there's the teaser for what's coming. And I'm going to show you just a couple more things to give you a sense of sort of what's included in this e-learning modules. So what is intimate partner violence? It's a person or persons, if you're in a polyamorous situation, someone in a relationship essentially who's using tactics to gain and maintain power and control over another person. And I think as we think about intimate partner violence, there's a classic image that kind of comes to people's heads. And I think that's the image of the black eye, right? So when we think about intimate partner violence, we usually are thinking about physical violence, but this e-learning series is pushing us to think bigger than that. How does power and control show up? And how does it affect your ability to get health care? How does it affect your health? So of course, intimate partner violence includes sexual violence, emotional violence, economic control. And so my friends who are on the call who are from rural areas, I grew up in rural Colorado, your partner might take your car keys, not give you money for gas, might forbid you from being able to call in to get more information from your healthcare provider. All kinds of things can be connected to, or take your phone, not give you access to a bank account. Trafficking is another element of intimate partner violence that many people don't think about, right? So trafficking, we tend to think about the guy in the white van driving you across state lines. And of course, what we know to be true about trafficking is it usually happens by someone known to you, right? So someone within your own family, including your own partner. And one of the things that we saw in COVID is a rise in trafficking as part of domestic violence. Reproductive coercion is another part of power and control, when somebody's trying to get you pregnant when you don't want to be, or someone's trying to control the outcome of a pregnancy in a way that you don't want, And I'm going to give you one more example of kind of how power and control shows up. And this is, again, helping make connections about things you may not have been doing in the past, but I'm hoping we inspire you to do them moving forward. And that's this. This was a huge survey done on the National Domestic Violence Hotline. Over 3,000 people were surveyed, and they were wanting to better understand how substance use coercion worked, right? So what we found is that 27% of the folks surveyed were pressured or forced to use alcohol or other drugs more than they wanted. But this is the one I want you to hold on to. 15% of the callers said they wanted to get help for substance use. All right, now hold your breath and notice. 61% of those folks said that their partner or ex-partner was trying to prevent them from getting help or discouraging them from getting help. So for us, I want to know if someone's struggling with smoking, someone's struggling with something else. I want to know the role of their partner in either supporting that or getting in the way of that. And so that's another element of the power and control we want you to look at. So let's shift. Intimate partner violence during the perinatal period. We're going to look at the facts really quick. And again, these are some of the slides that are included in some of the modules. To give you a sense of the prevalence of the problem, there were 5 pregnancy-associated homicides per 100,000 live births in 2020, and this is a notable increase from previous years. The rates were highest among adolescents and Black women, and this is one that, again, might be a surprise to some of you on the call. 80% of the incidents involved firearms. How many of you are talking to your clients about firearms in the home? I'm going to guess probably not a lot. And this is another opportunity for us to think about expanding the work that we're doing. We know also that the risk of homicide was 35% greater for pregnant and postpartum women than for their non-pregnant, non-postpartum counterparts. So we know this is an incredibly vulnerable time. And I'm so glad you're joining us today to think about how we can be serving folks. You know, often when people think about maternal mortality, they think about kind of the traditional, the traditional obstetric complications. So hemorrhage, preeclampsia, blood clots, et cetera. But I think what is less known is that pregnancy-associated homicide and suicide account for more deaths than those sort of traditional things that we think about relative to maternal mortality. The other thing that I think is important, and Ashley mentioned this earlier, you know, so how are we gathering data? How well do we understand what's happening in pregnant and birthing people's lives? And one of the things that differs state by state is what is included when they look at intimate partner violence related maternal deaths. And so some states are looking just at homicide. Some states are looking at suicide and substance use overdose with an understanding that intimate partner violence can influence both of those things. So for some states, they're capturing the data around folks who've experienced IPV and then overdosed, or folks who experienced IPV and then committed suicide, and pulling all of those numbers together. So the reason why this is a newer concept to the field is simply this. Until recently, deaths related to behavioral health were not considered to be pregnancy related and were not counted toward maternal mortality rates. So we're at a junction where we're thinking about things differently and more broadly than we have in the past. The other thing that we talk about in the series is the limitations of screening for IPV. And I know many of you use some kind of evidence-based IPV screening tool. However, there are evidence-based screening tools that are better than others, right? So there are some tools that focus exclusively on physical violence. And I don't know about you, but I'd like to prevent physical violence. I'd like to have tools that are helping me understand, is there other tension in the family? Is there other power and control dynamics happening? And do the tools you use lend themselves to conversations? And just so you know, there's a big body of tools to look at, and we talk about them in the bundle, that might be better than what you're currently using, and our evidence-based tools that McBee would support. So why do I care about this issue so much? Well, again, I think it's important to look to the field and the experts in the field. This is data from the Nurse Family Partnership. And here's what they tell us about intimate partner violence screening tools. The use of structured screening tools at enrollment has not been found to promote disclosure or in-depth exploration of women's experiences of abuse. Women are more likely to discuss experiences of violence when nurses initiated open-ended discussions that focused on parenting, healthy relationships, other kinds of things. And I want you to think about that for a second. If intimate partner violence has a lot of stuff associated with it. And, if I was sitting in my backyard with Ashley and we were eating tuna sandwiches together, I can't imagine saying, so Ashley, has John ever hit, kicked, slapped, or choked you? I would say, Ashley, last time we checked in, things were really hard with John. Can you tell me a little bit about how you're doing, how I can help, et cetera, et cetera. So I just think it lends itself to our thinking about what are we currently using, and should we make some changes? All right, so this is my first chat box question, my friends on the call. I'm going to ask you to answer the question why, and I'm going to set it up with this thinking. Have you or someone you know ever left something out of a medical history or intentionally misreported information to your healthcare provider? And if so, and I think all of us, if we thought about it, would say yes. We certainly know a client who's done it. We've done it ourselves. We know someone in our family who's done it. The question I want you to answer is why? Why do people not share their stories with us? What have you got for me in the chat? Shame, lack of trust, absolute fear of judgment, guilt, beautiful. Let's see here. Out of fear. Okay. No, those are all right. All perfectly right. Shame, embarrassment. And the one thing that we've missed here, and we did a review of barriers to IPV disclosure in this e-learning series. And the number one fear is that folks are worried their kids are going to be taken from them. So that's a big barrier to talking to people about intimate partner violence. And it's one of the things that we want to be thinking about relative to equity. Okay. So I'm going to keep building on that thought. Oops. So when we think about equity, when we think about how do we make the playing field level, how do we make sure everyone has access to everything they deserve to have access to? If we don't look at the barriers, then we aren't doing the right thing, because we know intimate partner violence screening doesn't serve everyone, because everyone can't tell us their stories, right? Maybe even so, universal education, we think, equals equity in health. It provides a strategy to treat clients with respect by giving them key information about healthy and unhealthy relationships and where to get supports without requiring disclosure to get them, right? This is the change. This is the thing that we can be doing in addition to intimate partner violence across all programs, models, all the things. Universal education tool, these are tools that were created, and we have been doing research on them for many years now at Futures Without Violence with partners in the field. These are these little business sites cards. They're multifold. They were developed in concert with survivors, healthcare providers, home visitors, and advocates. Some people say we have an app for that. At Futures, we say we have card for that. So recognizing that different communities have different needs. We have a trans focus card, we have an LGBT card, we have an Alaska Native focus card, and an American Indian focus card. We have youth focus tools, et cetera. So we've developed them for primary care, reproductive health, et cetera. What we're going to be focusing on today is this. A tool that was developed for perinatal case managers and home visitors. And I will say, it was a joy to work on this. We at Futures, like a lot of us in the field, have had to eat some humble pie over time. So we had a home visitation case management curriculum in the past called Healthy Moms, Happy Babies, which you might have heard about. And the problem with that is it automatically leaves out any birthing people out of the story. So we own that, and we developed a new tool and a new strategy that is gender neutral. So it invites all comers. And for this tool, given that many of us are working in home settings or having other family members come into visits, we actually created an intervention that's targeted toward the whole family. So these are universal education conversations you can have with all the comers in the family. Our intervention is called CUES. It stands for confidentiality, universal education, empowerment, and support. And when we talk about confidentiality, of course, what you would be doing is talking about the limits of confidentiality. So what do you have to do a mandatory report about? So you'd want to have that script done. And I say that as a general thing because different states have different laws. So you would need to create a script based on what was going on in your state with your law. The cards have many panels. I think there's 10 panels on the card. We are going to be talking today just about the IPV intervention. There's panels on ACEs, there's panels on parenting, all kinds of other things. But we wanted to create a really simple, bite-sized, step-by-step sort of guide for all of you. And as you're looking at this, I want to say something else, right? I'm this 57-year-old white woman living in California. And the beauty of cues is these are my scripts, right? They're not the right script for you. You're going to change and adapt this based on who your client is. If you've been serving them for 3 years, or if they're a new client, if they're a teen client, you're going to have your own voice and cadence. So these are just support tools, jumping off points, if you will, for how you might have these universal education conversations with your families. So here's step one. We're giving these cards out to all the families in our program. They have great info on what helps complicated relationships. We give you 2 cards, so you have one for yourself, but also so you can help friends or family. We give you one for them too. Step 2 is the You Matter script, and each one of the panels of the card has a little header on it to make it easy for you to find. So this is the first panel you read when you open up that multifold card. In this card, it's like they're breaking down the kind of stuff in people's lives that we don't always talk about, like laying out what helps families and what people deserve, being treated with respect, kindness, being listened to, feeling safe, and being supported in parenting. And you can imagine how important it is to lay this out, because for many people, maybe all they've ever seen are relationships where people hurt each other. And so if that's normalized to you, the power of you as the case manager person saying, hey, this is what we talk to everybody about, might be the first time somebody's heard that. And I'm sorry that my slide cut this off a little bit. Let's see here. Let me see if I can. So the complicated relationship script. And this was a really important one. And I'm so sorry. Let me see if I can fix this really quick. There you go. This complicated relationship script was really important in our conversations nationally. Folks loved it. And the nice thing about it is, who among us doesn't have a complicated relationship? It just kind of normalizes the conversation a little bit. So the other piece I wanted to share is that all relationships sometimes get complicated or hard. Like maybe there's name calling or other stuff that may be controlling us or hurts us emotionally or physically. So here we're looking at behaviors. We're not labeling things. This card helps us talk about how common relationship stress and problems are and what helps. And talking about this is so important because kids and babies need parents to be in the best possible space when things get rough, and supports can help. And then this is the other piece, right? This is the huge difference, the change from what we've been doing historically with screening and what we can do with universal education. And that is this. Every single family now gets information about where to go and get help. And it's not predicated on them disclosing intimate partner violence, right? So here are free anonymous 24/7 helplines on the back of the card, stuff you can share with friends and family too. And you don't have to be in crisis to make a call. They're there to talk to you and support you in whatever you need. The DV hotline has trained advocates who aren't judgmental, give support and advice about complicated relationships, both for people who are being hurt and those that cause hurt. Also, there's a supportive parenting line. But that line I said just a moment ago, for people who are being hurt and those that cause hurt, is the magic sauce, right? Because historically, when we look at intimate partner violence, we've kind of put the person that uses harm, the perpetrator, in a box over here and the survivor over here. And the truth is, families are complicated. Sometimes there's bi-directional violence. Sometimes people who hurt people were hurt themselves and they want to make changes. And the hotline can help with that as well. And so I don't think that's a piece that most people necessarily know about. Okay, so one more chat box questions, my friends on the phone. What happens when we frame this intervention this way? We're giving these cards to all the families in our program. They have great info on how to build strong kids and what helps support relationships. We give you 2 cards so that you have the info for yourself, but also so you can have help with friends. You can help friends or family. What happens when we do it that way? What happens when we frame things? It normalizes it. Thank you, Kara. Others, what did you notice about that? Or what did you notice about cues? Everyone gets the information. No threat, non-threatening approach becomes normalized. Thank you, Devin. Thank you, Art. Yeah, and I builds trust. Nice. Thank you, Ashley. Yeah, it does, right? So I think when we've created a conversation, we invite people in, right? If I was sitting in my backyard with Ashley, again, I wouldn't say, have you been hit, kicked, slapped, or choked by John? I would say, Ashley, let's talk. Last time you shared with me, stuff was hard, and I want to understand where things are, all the things. So screen in instead of screen out, Shelby. Love it. Love it, love it, love it. Destigmatizes abuse and needing to get support. Beautiful. Yeah, and opens the door for someone who's never known that maybe there was a place that they could get help or support for change. It also opens a door for that as well. Jocelyn says positively framed around health as opposed to negative around stigmatized topic. Yes, yes, yes. You can see why we're a little excited about the e-learning series and we're trying to reel you in because there's so much more. It was very hard to decide what I was going to talk to you about. But one other thing I will mention that is in, oh my gosh, I think it is. Yeah, there's a workbook that Futures has created working with folks who've caused harm and what kind of legacy do you want to leave for your kids. And it's another really powerful tool for you to have to support families. So thank you for your wisdom. Okay, now I also know you're experts, and I also know there's going to be situations where you're like, this feels wrong to me. I don't want to talk about complicated relationships with this family. We had the opportunity to pilot Connected Parents, Connected Kids as part of the IPV benchmark for McPhee and looking at opportunities to help support and broaden the work around IPV for home visitors. And, what was really fun about that is we had, I think it was 18 programs and different models were involved, and it was hugely powerfully received. We had stories of home visitors saying, oh my gosh, the dad said, I'm so glad you talked about this. This is what happened in my childhood, and I never got to talk about it. And I'm so glad we're talking about it here. I mean, we really cool things. And then there were a couple situations where the home visitor said, I didn't talk about it. I didn't feel good about it. So I waited till I was alone with mom or birthing person and had that conversation privately. So I want you to do a gut check. Our goal here, and you can see my sort of energy in the way that I talk about this. I'm not talking about this as intimate partner violence or domestic violence. We're talking about this as, hey, come on in and let's talk about the truth that's happening in families and what makes a difference, and I don't want anybody to feel like they have to wait to tell me in order to get supports. Like, this is something we should be talking about in our community and with our family and our friends. So little tips, you can use this as a opportunity to create inclusivity. And I want you to not talk about complicated relationships if it feels wrong. The other thing I want to say, and this is very important, I don't have a slide dedicated to this, but if you're using your evidence-based screening tool, you should 100% do that when you are alone with that client. You should never do an IPV screening tool in front of friends, family, partners, any of those things. So universal education is quite different than the way you approach an IPV screening tool. So I just wanted to mention that as well. So, I mentioned, like, I'm an old lady who lives in Berkeley, and these are my scripts, right? So when you come to the e-learning module, you'll have an opportunity to print out this tool and write your own script. And then what we do for our supervisor track is we say, hey, supervisor friends, at your next staff meeting, have everybody do this, and then they should practice their scripts on each other. They should get their feet wet. They should feel a little bit more comfortable. So there's lots of pieces that are about how do we center your expertise and your expertise in your family, and then create more culturally responsive connections, because we know that you're the center of the care model, right? We know you're the ones that are in your family's lives and make a difference. So this is a little, again, teaser for what's to come. The other thing that we want, even though disclosure isn't the goal, we know disclosures will happen. And so we wanted to support you all in knowing what to say. And I think one of my favorites is, you don't have to have the words. Sometimes people tell us things and we're just overwhelmed and trying to think about what to say. And I love the one in the middle here. So it says, I believe you, but this one I think is really great. I don't even know what to say right now, but I'm just so glad you told me. Thinking about those phrases, and you can be doing this in your staff meetings, you can be doing this yourself. What would your go-to phrase be? Our goal here is to give you more tools and support. So when you walk into a home, if there is a disclosure, if something hard comes up, period, that you have more support. So it goes back to sort of those modules, and actually we have a smattering of self-care throughout the entire e-learning course, but there's some specific tools around helping you take care of you by noticing where you are in time and space, and strategies to get back into your shoes if you're feeling triggered or overwhelmed by something that happens with the client. I also want to say that the domestic violence hotline is your friend. They are there for not just the people who are being harmed or the people who are trying to get help to stop harming. They're also there for healthcare providers. So you can call up and say, hey, I've got this client. Can you tell me a little bit more about ideas you have for me? I'm not sure how to start this conversation. Do you have ideas for me about that? The other thing you could do is, like, if your client is in agreement with this, you can always do a 3-way phone call. You can connect yourself, your client, together with the advocates, and that can make a big difference. So sample scripts over here. DV hotline is your friend. We talk about developing memorandums of understanding between community-based programs that focus on advocacy and healthcare systems, so that you all are closer together and maybe can even be working with the same family. I do want to say, in states that have done a really robust job of working on this, they actually sometimes have advocates, if the client approves, go on a home visit with them. I mean, there's really cool models out there that can support the work and support families better. So safer planning is client-centered. I mentioned this at the outset. So it builds on the strengths of what the survivor has already done, right? So that survivor is the expert in their own lives. It's truly survivor-centered and survivor-defined. It helps us learn about what motivates decision-making, and that helps us lead to understanding. So it's a very different model than maybe what some of you have been trained on in the past. And, safety planning tools are typically focused on leaving the relationship. And that's a problem in and of itself, because we know that staying might be the safer choice. We know that leaving comes with some of the higher rates of homicide or extreme abuse. So we never want that to be the goal, unless that's what the client wants that to be their goal. But for us, as the people who are working with the family, we don't want to be imposing ourselves on them. We want to be listening to what they know is going to work best, or what has been working best, and support that. So the essence of cues, what does cues do? It builds relationships, right? Those conversations in the backyard. It's strength-based and caring focused. It focuses on altruism, right? So we said, hey, we give you 2 so you can help other people. Well, what's cool about this intervention is that this little quote at the bottom, the power of social support is more about mutuality than about getting for self. That is, there's a need to give, to matter, to make a difference. We find meaning in contributing to the well-being of others. That's not just true for you all as the people who help people. That is true of your clients. And think about the power of saying to someone, hey, I know you're someone who can help other people, especially when they've been told that they're worthless, useless, all the things by an abusive partner. It empowers clients and the folks that they care about, and it shares power between the provider and the client. And here's some qualitative of the qualitative research we've done on cues. And this is a provider's perspective. The card made me feel empowered because you can really help somebody. somebody that might have been afraid to say anything or didn't know how to approach the topic. This is a door for them to open so they can feel more relaxed about talking about it. And here's what clients said. They would bring out the card, basically walk in with it. She'd open it up and ask me if I'd ever seen it before. It was awesome. She would touch on no matter what the situation you're in, there's something or some place that can help you. I didn't have to be alone in it. That was really huge for me because I was alone most of the time for the worst part. Another client said, getting the card makes me actually feel like I have a lot of power to help somebody. And what we know from our research, because we've tested these cards in many spaces, including with adolescents and school-based health settings and other places. And, sure enough, do people hold on to the cards and give them to other people? They do. So it's a very cool community-based intervention. I'm going to give you just a final, so we piloted the bundle. And so we did that in a number of places. And I've got 2 quotes to share with you about people who've already gotten their fingers and toes wet a little bit in this and some of their learnings. So I wanted to share this with you. So this is from the Domestic Violence and Sexual Assault Program Director at the City of New Orleans Health Department. So we really encourage that partners in the local maternity safety work group, recognizing the importance of incorporating IPV screening and assessment and universal education into their work, and are open to reaching out to the DV sexual assault program in the City of New Orleans for assistance when they need help with implementing these bundle elements. So you can see here is a beautiful example of a partnership that got created because of the bundle, right? So they're talking to each other, and they've already, the DV agency has already shown itself to be a ready and willing partner to the community healthcare intimate. I can't remember if this one was community healthcare or if it was home visitation. So you have to forgive me. I didn't do these pilots, so I couldn't remember. But it's either home viz or community clinic that was doing it. And then here's some additional thinking from the Center for Black Women's Wellness, and this is one of the AIM CCI pilot sites in Atlanta, Georgia. And here's what they had to say. After reviewing the IPV bundle, we realized we needed to standardize the approach to IPV. IPV is not just a symptom or a feeling. It's an intimate topic that is best addressed with universal education. Universal education is a process such that all people experiencing IPV have access to supports without disclosure. This is important because we know there are real barriers to disclosure. With IPV screening, so few disclose, it's clear we miss so many that need help. This approach allows us to engage in more conversations with clients and with families. So, if you're interested in the cards, you can order them from Futures Without Violence. They are free. We do charge for shipping, but it's a very small amount. And we'd be happy to share them with you there in Spanish and in English. And with that, I am going to turn it over to Ashley as we round out our hour.
Thanks, Rebecca. Every time I listen to you speak and we go through it, and I've seen the slides, but I pick up on something else. And I just think it's, what really resonates with me from the beginning of bundle development and hearing you say it again today and looking at, that shift in universal education approach, right? And including the person who's causing the hurt as somebody who also needs help and support. And I just think that, it's honoring that experience of the person causing the hurt and what that past might look like and what's, that cycle of violence. And I know it's not simple, and it's easier to, say it than do it, but that hope of ending that cycle of violence, I just think is really encouraging to me. And then just wanted to provide a little bit more context around those final 2 quotes out of New Orleans and Atlanta, that both of those are AIM CCI pilot sites who have helped us with not only bundle development, but testing of our community care initiative bundles. And those 2 sites picked up IPV. So as a part of AIM CCI, they've put together a local maternal safety work group to share this information throughout their communities. And if that's something that you're interested in doing, we can talk to you more about that. So wanted to also just let you know again, the IPV learning series is coming soon. It is currently under final stages of production. And as Rebecca mentioned, there will be 2 tracks that learners can register for. One will be specific to frontline workers, and the other is for supervisors to support organizational and staff well-being. The series was developed to help support implementation of the IPV bundle. However, it will be publicly available for anyone to pick up. It's free to the learner, and it is also accredited by APHA for 7.5 CEs. And once that's available, we will also be sure to send that along with the bundle out to everyone who's registered for this webinar. You can go to the next slide. So if all these things we've talked about today seems like something you would want to bring into your community, then we, AIM-CCI, are accepting applications for partners as part of our expansion part of our program. And all information, again, including the links, can be found on our website. We can drop the link to the application and to our bundle information in the chat, as well as follow up after this call. But we certainly would love to partner with you on bringing this into your community, to do all those things we talked about in the beginning, right? To raise awareness, to help with contributing to the larger body of data to inform where this work should go in community, and partner on, I think we can do some really great things and kind of shifting the paradigm here. So thank you once again for joining us. If you have any questions about the topics we've talked about today, please feel free to reach out to any of us. I'll also drop my email address in the chat. We always say at AIM-CCI, there is no wrong door. So if you reach out to anyone that's listed on this slide, then we will be happy to get the information that you're requesting over to you and to the right team member. So I think with that, we can turn it over to Q&A, unless Rebecca, you have anything to add. And I think lastly, we will also provide a QR code and a link to for the webinar. Can you go to the next slide?
Oh, sure. Sorry.
That's okay. Just want to make sure we have the evaluation QR code up there, and we can have that maybe on the screen while we do Q&A.
Great.
Did you have anything else to add, Rebecca?
Yeah, the only thing is the chat came in pretty fast and there's some questions in there, and I wondered if you wouldn't mind reading those questions, and maybe that can be the kickoff to the Q&A. Does that sound okay to you?
Sure. Let me find where we are because I haven't looked at it in a few moments. So the question about first access to the recording, yes, and Brittany already answered that one, that it'll be available on the website and you will receive an email once it's available. There was a comment about loving the inclusion of safer planning because of bandwidth and access to supportive services. May you post the link to purchase in the chat? Oh, to order the cards. About how to access ordering the cards.
When we send out, because everybody's registered, so we'll send out the link to Future's website and specifically to the Connected Parents, Connected Kids card after this. And I'll just mention again, it's in English and in Spanish. So thank you for that. Were there any other questions there, Ashley? And then we can just open it.
Has the NJDLC considered ordering the cards and getting them into the hands of community doulas who are already underpaid and incurring debt in an attempt to provide services and some of the most underserved and at-risk birthing families?
So you had me at doula. One of the things that I talk about in the e-learning series is the power of doulas in terms of supporting families. So thank you for everything you do. I love this idea that can someone else pay your postage is essentially what I'm hearing, and get those cards to you. And I think that's a great example of the kinds of partnerships this bundle can create opportunities to do. Like, you know, whether it comes from the home visitation program, maybe you can call your DV program and say, hey, I don't know if you all have money to order, you know, pay for this, but we would love to meet with you, understand what services you provide. And if you have any flexibility, if you could order these cards, then you could have them and we could have them. So I think that that's I wish I could fix right now you getting paid for what you deserve to get paid for, because we know that doulas can make a life or death death difference in the lives of birthing and parenting people. So anyway, I just wanted to say that. Is there anything
And
else?
I'm going to add on to that for communities who partner with AIM-CCI, part of that local maternal safety work group that we talked about forming includes doulas, absolutely, in that, right? Because we want to break those silos and share information across all touch points in a birthing person's experience, right? From as they're planning to get pregnant, through pregnancy, and that first year postpartum.
Right.
Oh, and it looks like Karen has her hand up. So I'm gonna see what Karen has to add.
Thanks, Ashley. Thanks, Rebecca. Always great to be in your company and hear this information again. It makes me so excited that we developed this bundle, which I think is an absolutely innovation for looking at maternal mortality. But I just wanted to ask, relative to Karen's question about having the cards available and accessible without cost, did you mention, and I'm having a little bit of brain fog here on, in the learning series, if somebody registers for that and goes through the learning series online, will there be a link to download and print the cards? So then that's one way to potentially, or is it a link to order the cards?
It's a link to order, and the reason
Okay.
it doesn't work that way is because, remember I mentioned they're multifold. So it's actually a special process to make sure that you can imagine printing it, or maybe you can't, but because it goes 1, 2, 3, 4, 5, 6 kind of thing, it just doesn't work to print it out flat. It would,
Yeah.
and the postage, if you order a few cards, it's some dollars. If you ordered 1,000 cards, it might be, I don't know, whatever the weight. It's by weight. It's not anything other than that. And I do think this is an interesting idea, Karen, for us to think about relative to, for example, Healthy Start. If there are programs that are worried about their budgets, maybe there's a way for, Healthy Start to cover the posters. I don't know. I don't want to put you in the hot seat, but, I do think that there's innovative ways, and my other dream, and the other thing I talk about in the e-learning series, is I would love home visitors to be key partners, actually go into community health centers, so that there's, again, more arms around people. And that might be a place where the community health center can order the cards for the doulas and for the local home visitation program. So I see a hand up. Do you want to come off mute and ask your question?
Hi, hello, can you hear me? Hi, Rebecca, so nice meeting you again. Dr. Miller referred me to learn about the car from you several years ago. It's amazing to see the progress. And would you share the history about the car, like how many years and how many versions? And also another question, because for early home visiting programs, there's mandate to have IPV screening, and to integrate the universal education through different ways, including CAR and also IPV screening. Do you know which organization may have the data about those education components? It's amazing to see screening. I don't know if they really reach pretty high level, but truly identify family with IPV issue. But also education could be, most of the family in early home visiting setting could receive those CAR, also be really educated. Thank you.
You asked a whole bunch of questions, so I'm going to try my best to get to them. And I know there are a couple other folks on there. So the history of the card. So these cards were born out of mistakes. And we actually had an entirely different idea about how to do this NIH-funded project around, educating clients. And this was in a reproductive health setting. So we were looking at helping make connections around, partners who wouldn't let you use birth control, and partners who you were afraid of because you have a chlamydia or something like a sexually transmitted infection, and it was going to be dangerous for you to share that with a partner. I mean, we were looking at all kinds of tabs. We had literally, I think, highlighted photocopied pages, and it became immediately clear that was stupid. And so we immediately realized we needed to do something smaller, more succinct. It needed to make sense. And the safety card was born. So we developed those live on site. I will say I was a former Planned Parenthood clinic director. And so it was done at Shasta Diablo Planned Parenthood. There were 5 different sites involved. And it was very meaningful. So it's born there. We test it with clients, we test it with clinicians. And so now we have the printed cards and we're doing the thing live, right? And so I've got this health educator in front of me, and the health educator saying, so, we've started doing this with everybody. Here's why, and, would you like a card? And the client said, well, actually, I'm not in a relationship, so I don't think so. And the staff person turns around to me and says, oh my gosh, what do we say now? And I said, well, actually, maybe you want the card, right? Because maybe someone who needs it and maybe you can pass it along to them. And that client stopped, and I will never forget this as long as I lived. And she said, can I have like 8 of those cards? And that was the moment where the altruism piece and the power of one another in caring for each other was born. And that's sort of how the Q's intervention kind of went from one place to the next. And it was just a series of happy mistakes, happy tryings on. And I think the one thing I want to say about how does universal education work relative to the screening tool, right? I don't want anyone to lose their funding. I don't want anyone to get in trouble with McVie. I want everyone to continue until we change everything. And, maybe we will, maybe we won't. But I see the universal education cues approach happening on one visit with the family. And then it's a great segue, right? So you've now had a conversation about complicated relationships, the hotline number, all the things. And so you follow up, remember, because we're going to do that screening tool one-on-one. That's the only way to do it safely. So you're going to say, you know how last time we talked about complicated relationships and with that little card? So this time, I actually want to go a little deeper in understanding your relationship, right? So I'm going to give you this tool to fill out. And I also just want to say to you, I want to hear anything you want to share, but I also understand you might want to skip things, and that's cool with me too. And you have an opportunity to get deep in that relationship and use it as a segue into the deeper questions that sometimes I think can feel a little jarring and out of sync with where things are. But I think the Q's intervention offers you a gentle segue into the other. I am wondering, Ashley, were there any more questions? We're almost at time.
I'm seeing requests for PowerPoint and some comments about barriers.
You want to read the comment about barriers?
Sure. Karen also noted that she is an independent doula and that home visiting is not the premier partner in Cumberland County, as they are only mandated to ask if birthing families want the service and do not build a rapport in advance. In addition, they do not reflect the consumers they are trying to service, so there are a plethora of barriers that are not conducive to birthing family engagement.
Mm. Well, thank you for that. Thank you for that noticing. I just want to thank each one of you on this call for the way in which you show up in people's lives. It makes a difference, whether you're a doula, a home visitor, a nurse, someone who's managing nurses, doulas, and home visitors. If you're a project officer, I hope you all sort of see the power of what you do. This e-learning series, this bundle, is really a heart project of many of us who've been doing this work across disciplines for a very long time. And what you do matters every single day. So thank you for what you do. So I'm going to stop my share. I'm going to wave my hand, see if there's anything else. Thank you, Patricia. I'm so glad you could do this today.
Aman, do you need to do anything in closing, or Brittany?
I just wanted to take the time to thank you both for all of the information that you've given us today. And we are so very grateful, and we hope you all have a great day.
Thank you. And please fill out the evaluation, because we always want to know what we could have done better, what we can do in the future. So thank you again.
Thank you. Bye.
Thanks, everyone.